Okay, so this is Gerdy's tubercle and this is the lateral epicondyle, and for our lateral extra-articular tenodesis we'll be making our incision between the both of them. So you can see that's our skin incision. Pick up. So we cut through here all the way down to Gerdy's tubercle, clearing the space. Alright, and then you can identify the lower border just here of the lateral iliotibial band, and we're going to start our incision. So this is Gerdy's tubercle, so we start our incision here and we cut through to the Gerdy's just there, and you want to have a 10 centimeter incision, and then the upper leaflet of the incision passes here with at least a 1 centimeter diameter. When we release it off here, okay. So dissecting it free from the underlying soft tissue and the muscles. Okay. So you can see it's, then we peel it off, the underlying soft tissue and the muscles here. You can see it's being released on both sides now. It's good. ये cup बंद करोगे? Okay, so that's our leaflet for the lateral extra-articular tenodesis. So we're going to whip stitch our leaflet just there, and here you can see the lateral collateral ligament. So now we want to expose our lateral collateral ligament, so we'll use an artery and some scissors. So you can see the lateral collateral ligament in its entirety there. So you can do a bit more dissection if you want as well, if it helps you. You can also take the knee into a figure of 4 position to allow it to be easier to identify. And then once you've got your lateral collateral ligament in your tissue forceps, then we make 2 small stab incisions, anterior and posterior to it. So one incision goes anterior. You want to try to avoid violating the joint, but even if you do, it's okay because it gives you a reference of where to put your iliotibial band. So here I've dissected out the anterior and the posterior portions. I take a small artery now and I run it underneath my lateral collateral ligament, you can see there, and I dilate it out to create space for the passage of my graft. So then I want to capture my graft into this, which has been whip stitched, and we use this technique just to create some more space for easy passage of the graft, and you can see the graft coming through. Now sometimes it may turn on itself like it just has, so what we can do is we can shuttle it in properly like this. That's good. All right, now we go up, so get a small retractor in here. Okay. And then we want to identify our lateral epicondyle just there, and we make a small, so what I do is pottery, so I'll make a small incision just posterior to it over here, and that gives me a reference point for where I want to put my this, and staple. So then we ask assistant to hold it like this. And now the biggest thing is you want to avoid tunnel coalition. So your ACO tunnel, you can always track it out, and you can see it's passing up here. So we want to angle it in such a way that it's not going to hit our ACO tunnel. So what I do is I turn it like this and I use a staple. That's, so the first few I've got my iliotibial band very tight. And then to avoid maceration of the graft, I gently release a bit of traction on it and then do the final retraction. That's it. And you can see that it's sturdy now. That's good. Okay, and I'll just demonstrate to you that you've just done the LET, and this is the anterior draw. There's nothing there. So you can get away by just doing a LET in cases of partial tears, in cases of partial graft tears. So this is our tunnel, and you can see that the staple is not protruding through our tunnel, and then we can always slide our suture. So we're sliding our suture and shuttling it just to make sure that it's not interfering, the staple isn't interfering at any time.